All right. Good afternoon, everyone. Thanks for those participants who are joining us today, and welcome to this virtual meeting. Welcome everyone for logging in and attending the meeting today. Understanding, obviously, there's a lot of challenges right now with helping patients with education and administering care, but we really appreciate the efforts on our patients to cooperate with this and really reach out to us and learn virtually. So hopefully we'll be able to have a very educational session today, and I'm very excited for it. So my talk today is on understanding knee pain. And this is a really important issue. The burden of musculoskeletal pain and disability is really one of those things that we don't really talk enough about. But for many people, this can be a really challenging issue in life and sometimes even cause some debilitating issues. And even though obviously there's many other important medical issues out right now, these things still persist. So it's not as though these things go away. So certainly it's something we're very cognizant about and want to deliver the best care for our patients, even with some of the limitations around the current situation. So we'll begin with our agenda today. I'll actually give a little bit about my own background. We'll talk a fair bit of time about the anatomy of the knee, and this is actually quite important because when we're in the office, understanding where exactly the problem is, where the pain is in the knee is really the first step to understanding why the pain is there, and then obviously how to best address it. We'll talk a little bit about why the knee can hurt and what are some of the common and uncommon symptoms we see in knee pain. We'll talk about some of the evidence-based non-operative solutions for chronic knee pain, including medications, weight loss, wellness, physical therapy, bracing, and injections. And we'll also very briefly talk about some of the operative solutions. Now, we encourage our participants to have questions, of course, and on the application, you can actually enter or type these at any time during the talk, and we'll try to set aside a few minutes at the end, if we have time, to address these. There will also be recording online of our talk today at onsmd.com. And if you have any suggestions for this talk or future talks, please send us a message. I'll put those links at the end of the talk as well. So a little bit about my own background. I was born and raised in Buffalo, New York. I then did my undergraduate training at Stanford University in biology. There I also did some basic science research in microbiology and also tibial bone fracture healing and stem cell research. I then went to the University of Chicago for my medical school and medical training, and then did my surgical training in orthopedic surgery at the University of California, San Francisco, followed by some additional subspecialty training in advanced hip and knee reconstruction techniques at the Rothman Institute in Philadelphia. So I've really been all over the country and now back here in the Northeast and enjoying Connecticut and Greenwich as well. My clinical focus is on orthopedic surgery and trauma. I also see patients for non-operative management of hip and knee arthritis, and also help patients who require hip and knee replacements, and also revision surgeries for failed joint replacements. So I think this is a good place to begin for knee pain, is really where does it come from? And broadly speaking, when we think about this, we first off have to acknowledge that it can be very challenging to do. I mentioned earlier that when I see patients in the clinic, this is really the number one thing that I spend time doing. When we think of the areas in the knee, we split it up into two different areas. The first is inside the knee, which is intra-articular. So intra is inside, and this includes areas inside the knee, including the bone and cartilage, synovial tissue, which is the lining inside the knee, the meniscus, which can provide stability and cushioning inside the knee, as well as ligaments, which are primarily there for stability of the knee. Now, outside the knee are many structures which can cause pain that we localize to the knee area, but are actually outside of the knee joint itself. So these are outside of the knee joint, they are extra-articular, and these are tendons, muscles, bursa, which are essentially small fluid-filled sacs, which are normally occurring in the body, and even nerves. So we'll begin with some anatomy of the knee intra-articular or inside. And so the main areas of the anatomy of the knee from a bony perspective include three main bones. This includes the femur, which is on top in the thigh, as you can see in this frontal view, the side view in the middle of the screen, and then an oblique view from the right side of the screen. The tibia, which is sometimes known as the shin bone, which is in your shin or lower leg. and then also the patella, which people often refer to as their kneecap. And as you can see in the knee joint, we actually think of a joint between the femur and the tibia, and then also the joint between the backside of the patella and the front of the femur. Those areas of the bone are capped by this smooth, white, low friction material, which is known as articular cartilage. And articular cartilage has several important characteristics, which I'll bring about later in the talk, which are very unique to that substance, which when disturbed can cause some symptoms. In between the articular cartilage, between the tibia, again in the shin, and the femur in the thigh, are two meniscus or menisci. You have one on the lateral part of the joint, one on the medial part of the joint, and these are essentially additional structures that provide some compression stability, translation stability, and they help to disperse the forces in the knee for cushioning purposes, essentially. And as you can see, what they actually do is they improve the congruity or conformity of the knee, which is important for spreading the load of weight across the knee equitably, and also aid in stability of the knee as well. The last thing we mentioned here are ligaments. So some of these ligaments are around or inside the knee. These include the anterior cruciate ligament, often known as the ACL, or the posterior cruciate ligament, also known as the PCL. And then on both sides, you have a lateral and medial collateral ligaments, which also provide stability for the knee as well. In terms of some of the common areas of the knee outside that can cause some pain, include tendons. The two main tendons we see in the knee are the tendons above and below the patella. So again, remember the patella is the kneecap. So these are the two tendons above and below the kneecap, and they are called the quadriceps tendon above the kneecap and the patella tendon below the kneecap. And these can potentially be some areas of pain outside the knee. Similarly, I had mentioned before, these bursa, which are normal fluid-filled sacs, these essentially exist anywhere in the body where there's areas of potential friction, and these sacs of fluid essentially serve to cushion that area and provide some more frictionless gliding. And when they're inflamed, that is known as bursitis, and that can potentially be an area of pain. Now, I want to spend a few more minutes talking about knee arthritis and cartilage because that is probably the most common reason that I see patients for chronic knee pain. So I think it's important to understand. So, cartilage and articular cartilage is a pretty amazing material in a normal, healthy knee or hip. It provides cushioning, frictionless gliding, and it has many other chemical and molecular and physical properties that are pretty unique to that material, which help to maintain a very smooth and painless joint. And so on the top right, you see articular cartilage in a healthy joint. You can see it's sort of glistening, it's smooth, it looks very slick as though there's very little friction. And then to the bottom of the screen, you see an area that's affected by osteoarthritis. And you can see that, relatively speaking, it is not very smooth. There's some asymmetry. There's undulation to the surface, which can provide friction, as you can imagine. And then there's areas of redness or inflammation. And that's what we typically see when we have wearing and tearing of the cartilage or osteoarthritis. This is another view of what we see when people have osteoarthritis or wear and tear of their cartilage. So toward the left side of the screen, we see an X-ray of a normal knee joint. And again, to orient you, the femur bone is up top, the tibia bone is down below, and the patella bone is actually right in the middle. And again, you can see in a normal healthy knee, there's this empty looking space in between the tibia and the femur. And that is actually cartilage, which is normally occurring there, and it looks empty there on the X-ray. It's not actually empty. When we go over to the X-ray toward the right of the screen here, you can see a pretty clear example of knee osteoarthritis. So again, the femur is up top, the tibia is down below. And you can see an example where if you wear through all of the cartilage, you have the lack of that empty looking space. And as you can tell, that's something that can be potentially very painful for somebody. When you have arthritis like this, where essentially all of the cartilage has been worn through or is gone now, we describe that as being severe osteoarthritis. So, a good question is, why does arthritis, or why do some of these chronic conditions of the knee, why do they actually hurt? So, again, we mentioned some of the special properties of cartilage. When we lose some of those normal functions, including normal lubrication of the joint, and then the injuries to the cartilage, which we saw in those photos, that can lead to increased friction. When the cartilage is thinned, that leads to some increased transmission of forces to the bone on both sides of the joint in the femur and the tibia, and that can cause pain. The cartilage actually has no nerve endings in it. However, the bone does. So it's typically when the bone sees more pressure or has changes that people begin to have pain. A secondary finding in knee osteoarthritis can be bone spurs, which are essentially a secondary symptom of arthritis, and that can lead to limited range of motion or stiffness. It's pretty common. And people can perceive this as pain, swelling in the knee, as well as stiffness. Some other common symptoms. People tell us that they'll have some limited ability for walking. So let's say they were walking for maybe an unlimited distance before, they'll come in and say that they can only walk for 10 or 15 minutes before they have significant pain, or in the case of having severe arthritis, potentially even less. Sometimes people will occasionally need the use of an assisted device such as a cane or even a walker. People often describe a pain with stairs going up and down. Crepitus, which is the sensation of joints cracking or popping, or even the sensation of some mild, sometimes people describe it as almost Rice Krispie type sensation in the knee. If you were to put your hand in the front of the knee and you extend and bend the knee, that sensation of sort of that crackling and that popping is known as crepitus, and that's another symptom we have with the uneven and not roughened surface of the joint. And then stiffness, which often presents with difficulty putting on socks and shoes, or getting in and out of a car, or getting out of a chair, or in and out of bed. Fatigue. So some patients, especially those who have maybe a higher pain tolerance or sense their pain in different ways, will actually not feel direct pain necessarily, but will feel fatigue. So this would be a patient who says, hey, I can't walk as much as I want to. I feel wiped out at the end of the day. I don't really know why, but my family tells me that they see me limp, but it's weird because they don't feel pain. This would be an instance where fatigue may actually be the primary presentation of the painful stimulus from the osteoarthritis. For more severe cases, people can also have some malalignment or deformity. So to the picture on the right, you can see this gentleman has relative knock knee, which we call varus deformity or varus alignment of the knees, and that can often be associated with having severe arthritis and the wear and tear of the cartilage. Some uncommon symptoms include burning pain, numbness or tingling in the area of the knee, radiating of pain down to the foot or to the ankle, conversely radiating of pain from or to the lower back, rash or significant redness, or pain that's really not so much present with weight-bearing activities or walking, but seems to be worse at rest or at night. These patients sometimes describe these symptoms as having almost like a restless leg type picture. And I bring these up because this is another important extra or outside the knee issue that can sometimes present. And these are typically symptoms that are usually associated with nerve irritation. And nerve irritation that is associated with this usually is coming from the lower back, which is the lumbar spine. So one thing I wanted to mention is that the terminology for some of these things can be confusing, and I probably use some of these terms interchangeably during this talk. So you may have heard of terms such as arthritis, osteoarthritis, degenerative joint disease, or arthrodesis or post-traumatic arthrosis. And for the most part, these are very similar. And when I talk to most patients in regards to, chronic knee pain, degenerative knee changes, and arthritis, these are truly sort of interchangeable terms. And the reason why that is that, when you have joint space narrowing, when you have narrowing of the cartilage, wear and tear, or thinning of the cartilage, for whatever reason, be that from trauma, a history of infection, or slow degeneration, because the end result is very similar, we often describe this picture in a very similar way. Now, there are a number of non-operative things we want to do for people that have chronic knee pain, and these are some guidelines from the AAOS and the AAHKS, which are our main academic organizations that make recommendations based on the best available data. So the first is a non-operative solution, which is medication. And so there's very good data to support the use of anti-inflammatory medications for symptomatic knee arthritis. Some of these names probably look very familiar to you. So these include naproxen, ibuprofen, meloxicam, celecoxib, or diclofenac. I also included their brand names there as well because sometimes there can be some confusion about these. And these are all medications that are very similar. They act on the body to decrease pain and inflammation. And for the most part, they are very effective for the treatment of osteoarthritis. One thing I do want to note is that medication often works better in combination. So a very common question I receive in the office is, can I take my anti-inflammatory or the NSAID medication with Tylenol? And the answer is yes. And in fact, I encourage that for most of my patients. The reason is that unlike the medications between the same family, including Aleve and Motrin, or Aleve and Celebrex or Voltaren, Tylenol actually is a completely different medication. So in general, when you take multiple medications, they have a synergistic effect, which means that they work together to give you equivalent or better pain relief with lower doses of medication. So generally speaking, this is a very safe thing to do. One thing I'll note is that you should not take multiple medications within the same family. So you should not take Aleve and Motrin or Motrin and Advil, because those are actually similar enough that you would run up against getting some of the untoward side effects of that. Last is that we always try to avoid opioid medications if possible. There are many, many reasons for that. And I think a lot of that has been brought up in the popular media as well as some of our previous talks. But for all of our patients, what we find is that opioid medications, not only are they rife with potential complications, but they actually do a pretty poor job of actually helping you with knee arthritis pain. So we try to avoid them if at all possible. The other solution that's pretty helpful for patients, and there's moderate support for this in the literature, is for maintaining a healthy weight. And so maintaining a healthy weight, which is a BMI, which is a calculation of your height versus weight. This is usually something that you discuss with your primary care doctor, and I often bring this up in the office as well, is to maintain a healthy body mass index. And how is weight loss effective? So in the knee in particular, this is very effective, and that's because every pound of weight change a patient has, either a loss or a gain, leads to a 4-fold change in force transmission through the knee. So the example I usually give is that, let's say you were determined to lose or gain 10 pounds, using the 4-time multiplier, and assuming you did 5,000 steps per day on that leg, that would be 200,000 pounds more or less per day. And as you can imagine, that can have a significant effect on someone's knee pain. And I've actually had patients who have come in with knee pain that almost perfectly matched their recent weight gain. Conversely, I've seen patients who came to me who were interested in having a knee replacement surgery, and I began by having them go to achieve a healthier weight, and they actually found that the knee pain improvement was so significant they were actually able to postpone or even cancel even considering the surgery, which I think is a fantastic thing for them. The other thing to mention is that elevated body mass index is associated with having increased complications if you ever do need surgery. It's actually associated with complications after almost any surgery, but certainly after total joint replacement. If you look at the chart below, you see that there's a clear inflection point, which means that if you look at the axis on the x-axis horizontally, which is the BMI, as that increases above 35, and on the y-axis to the left, which is the vertical axis on that graph, which is your risk of having a complication. In this instance, the risk of having a deep infection, which is a very serious complication after a knee replacement. You can see that the risks really shoot up very dramatically with an elevated BMI, and this would be associated with people who are really more toward the obese or severely obese categories. And so this is something that's very important to consider if you're ever considering having any surgeries in the future. We do know that wellness is very effective. So wellness and aerobic activities, neuromuscular education. So that's going to the gym, aerobic exercises, doing classes. Low impact exercises are often very helpful. It includes elliptical bike or any aqua therapy in the pool can be very effective. And one thing I mentioned about this is that, people often say, why should I do this? Is this going to undo the arthritis? And what I often counter with is that, these really don't reverse your arthritis or undo the arthritis. Truthfully, nothing we do other than surgery can cure it completely. But for many people, this is so significantly helpful to improve the function and symptoms. I recommend it for all my patients. Next is bracing. So there's not very good data for bracing, so I don't routinely advocate for its use. For patients who do want to try bracing, I generally recommend a soft neoprene brace, which can provide compression, but I generally try to avoid any rigid braces or anything with a hinge. The next are injections, and there is inconclusive recommendations for injections, and I'll describe why that is. Injections that we do in the office typically are steroid injections, and that involves two medications. One is a local anesthetic, which is a medication like lidocaine, and then steroid. The steroid is what really helps to decrease the long-term inflammation and the pain. The local anesthetic usually works temporarily. The benefit is that it's easy to do, it's quick and quite safe, and may last. The downside is that it's generally temporary relief, so it's not a permanent solution for this problem. And that's why we have an inconclusive recommendation for cortisone injections. They are, easy to do and safe, and they're quite effective, but they aren't a long-term solution. The other injection we talk about is viscosupplementation. And the reason why I bring this up is that, this is a good option for some patients. The data for viscosupplementation, which is sometimes known as the gel shot, the coxcomb shot, the trade names include Orthovisc, Synvisc, Euflexa. For about half of patients, if you look at the data, you can get a very good relief, but about half of patients get no benefit. So if you add up all these patients together in a study or in a large study known as a meta-analysis, overall we see a modest benefit, actually not a very large benefit. For me, I think for patients who are really interested to delay or avoid surgery for some period of time, I think it's something worth to do, but I have the conversation with all my patients that this is not something that we know will be helpful over the long term. And one thing important is that these are made out of a constituent material of normal joint fluid, and I think early on people were under the impression that maybe this turned into normal cartilage or this would somehow restore the knee. Now, that doesn't actually happen, but it does have a very good pain relief effect in some patients, which is why we recommend it for certain patients. The next kind of injections we talk about are more biologic injections, which include stem cells. So stem cells are things you almost certainly have heard of recently in the news. So the idea behind stem cells is that they are progenitor cells, which means that they're very primitive cells that can theoretically develop into any number of different cell types, including muscles, liver, intestine, even brain cells or blood cells. And the idea is that if we were to inject this into a knee or to a painful joint, could this turn into normal healthy tissue? Now, the truth is that this is not the case. It doesn't necessarily happen that if you just inject stem cells, it sort of magically knows to turn into whatever material you're hoping it turns into. And overall, the literature is very conflicted on effectiveness of stem cell therapy. And currently, the best available data says that there is not strong evidence in support of its use. If you look in the popular media, it's everywhere essentially. Is stem cell therapy for arthritis safe and effective? Is it a promising treatment or a hoax? And then, unfortunately, there are sort of cautionary tales of people that are using this before we really know if it's effective or not. And based on the most recent and best quality data on large studies that we do have, currently it's the position of our main academic organizations and my own position that some of these biologic therapies, which include stem cell treatment and also PRP, which is platelet-rich plasma, it's based on a similar idea where you donate blood and then that's spun down by a centrifuge and then re-administered. And both of these are not recommended in treatment of severe knee osteoarthritis. And I bring it up here because it is something that you may hear about or see about in advertisements. It's usually very, very expensive and on the most part not shown to be better than placebo, which would be a saline injection. So not something that I think is worth it to do. In regards to surgical treatment, now this is really something I think we only talk about when you've really exhausted all of your other all the other attempts at conservative treatment and non-operative management, and this is really a personal decision. My criteria is that you really want to see some evidence that you have a true mechanical problem based on the examination and the x-ray. And then more importantly is, how are you doing as a human being? So are you actually having daily symptoms? Are you having any limitations in any way? That could be work, recreation, travel, playing with your children or grandchildren, things of that nature. And again, have you really tried all the conservative treatment that you'd want you to try? And again, this is really a quality of life decision. So, I tell patients this is not a tumor, this is not a heart attack. This is something that really is something that can improve your quality of life. but if you don't really have any limitations to your quality of life, it's not something to be actively considering, in my opinion. Briefly talking about some of the surgical treatments, arthroscopy is a minimally invasive surgery using 2 small or 3 small incisions in front of the knee. This can be helpful for certain conditions of the knee, but truthfully for severe degenerative changes of the knee is not generally effective, although there can be rare exceptions to that. Reorienting the joint or an osteotomy can be effective, so that essentially involves making an osteotomy, which is a fracture that we create in the operating theater, which is to break the bone below or above the joint and then reorient the joint and fixing it, and that potentially can be helpful. And then last are replacement procedures, and there's 2 of these. One is a partial knee replacement, sometimes known as a unicompartmental knee arthroplasty or knee replacement, and a total knee replacement. And I have diagrams of what a total knee replacement and a partial knee replacement look like at the top right of the screen there. And again, you know, for the most part, those are things we really try to wait to do if you really have prolonged symptoms. And obviously, these are always things you want to have a discussion with your primary care doctor and potentially your surgeon before you undergo any of those. So, you know, I really appreciate everyone's participation listening to the talk. Again, I feel very strongly that, you know, the burden of musculoskeletal problems and pain is really something that can be debilitating or life-altering in some patients. So we always seek to restore people as much as we possibly can. So we appreciate your patience and appreciate your attention for this talk. There will be a recording of this talk online at onsmd.com. And then again, if you have any suggestions for this talk or feedback and any suggestions for future webinars we can do of interest, please let us know at contact@onsmd.com.